Hi, I'm Charles Wykoff, medical and surgical retina specialist from Houston, Texas, and it's a privilege to be able to talk to you about a drug called pegcetacoplan. This is a drug that's been studied for treating geographic atrophy now for many years, and it's an exciting time because we now have 2-year data from the phase 3 program. So geographic atrophy is one of the manifestations of late age-related macular degeneration. As you know, AMD, or age-related macular degeneration, is one of the most common causes of blindness in most developed countries around the world and causes more blindness than everything else combined in the United States. And there's 2 ways that people ultimately lose vision, lose central vision, and go blind from macular degeneration. There's the neovascular form called wet AMD, for which we've had treatments now for nearly 2 decades that work really well by injections into the eye, called intravitreal injections. The other manifestation of advanced AMD, called geographic atrophy, has no treatment today. Geographic atrophy can, of course, occur in isolation, but it can also occur concurrently with wet age-related macular degeneration. So a treatment for geographic atrophy really represents one of the largest unmet needs in all of retina care across the U.S. today. There's no treatment for it. Many patients are losing vision from it. And this is exciting because this is a drug that now has completed phase 3 trial data with an impending FDA decision later this year, and we'll talk about that later. But at the AAO this year, at the American Academy of Ophthalmology, we presented 2-year data from the OAKS and DERBY phase 3 clinical trials. So these were global double-masked phase 3 trials that enrolled 1,258 patients, so very large phase 3 program, all with geographic atrophy. And it randomized them equally to one of 3 arms. One arm was pegcetacoplan 15 milligrams every month, intravitreal injections. Second arm was pegcetacoplan 15 milligrams every other month, intravitreal injections. And the third arm was actually split in half, or sham injections, either every month or every other month. So 1/3 of patients got sham injections. The primary outcome was at 1 year, and we presented that data last year at the AAO. And then this year we're presenting 2-year data. So patients remain on their dosing schedule through a complete 2 years. Interestingly, after the 2-year trial, there's an ongoing extension study, an open label extension study called GALE, G-A-L-E. That trial is ongoing. It's open label, so all patients will be treated, but the first 2 years is sham controlled. So from a findings perspective, really 3 major buckets to talk about. We'll talk about efficacy, safety, and then function. So from an efficacy perspective, what we saw was that at 24 months, the end of the phase 3 program, the treatment effects of pegcetacoplan were similar between the studies, OAKS and DERBY. With every other month dosing, there were reductions in geographic atrophy lesion growth by about 16 to 18%, and with every month dosing, the reductions were about 19 to 22%. Diving a little further into that, what was most interesting at 2 years from an efficacy perspective was the fact that when you look at 6-month segments, what you see is an increasing treatment effect of pegcetacoplan over time, particularly in the last 6 months. And during that time, there were 24 and 30% reductions in geographic atrophy lesion growth with every other month and monthly dosing respectively. Substantially greater growth reductions than, say, for example, in the first 6 months. Fascinating to see that, and there are a lot of potential biologic explanations for that that are being investigated and considered. But that is very exciting for potential clinical application if and when this drug may be approved, because that would translate into increasing benefits for patients the longer they take the medication. That's efficacy. Let's move on to safety. The most interesting finding that we saw in phase 2, that was a trial called the Philly trial that we reported on a few years ago and is published. The most interesting finding there that's been replicated now in phase 3 is an increased incidence of wet AMD development, or what's defined in the protocol as exudative AMD, through pegcetacoplan treatment. And those percentages are about 12, 7, and about 3% in the monthly, every other month in sham arm. So what we're seeing is that patients that get active treatment with pegcetacoplan have a higher incidence of developing wet AMD in their treated eye. Again, a lot of very interesting biologically plausible ideas about what might be driving that. that are under investigation to understand that signal more. But that's a very important clinical pearl to be aware of, that if and when this drug is approved, we need to make sure that we are monitoring patients for the development of wet AMD in the treated eye. Because in the study protocol, in the phase 3 program, patients continued receiving their study drug treatment and also received anti-VEGF therapy at investigator discretion when and if they developed wet AMD. And overall, those patients performed similarly to patients that did not develop wet AMD in the study. So we think it's possible to treat these two manifestations concurrently in the same eye with 2 injections at the same visit. That's how they were managed in the phase 3 trial safely. The other points from a safety perspective are inflammation and infection. So the infection rates were very similar to what we see with anti-VEGF clinical trials. The rate was 0.034% per injection. And then from an inflammatory perspective, the rates were about 3.8, 2.2, and 0.2 in the monthly, every other month in sham arms. So there were some cases of inflammation with study drug treatment. 2 things to say about that. One is some of those cases of inflammation, particularly the severe inflammation cases, were from 2018. This phase 3 program initially got started and had some inflammation. The trial program was stopped and a new drug product was created that had much less inflammation, and that was initiated in 2019. So since starting 2019, the large majority of these have been mild, and most of the patients, 77%, have continued or resumed study drug treatment without inflammatory recurrence, and there have been no cases of retinitis, occlusive vasculitis, or retinal involvement. All of these have been anterior segment, anterior vitreous, or iris involvement of the inflammation. Okay, last topic to cover here is the functional data. And this was exciting because it was pre-specified to only look at the functional outcomes at 2 years. So we did not look at all of the functional outcomes at 1 year, only at 2 years, and that's what we're presenting this year. And 2 points to make. First of all of the pre-specified functional endpoints, there was no difference between the treated patients and the sham patients. That included the key secondary endpoints: best corrected visual acuity, reading speed, FRI index. For example, if you look at best corrected visual acuity through 2 years, all of the arms lost vision. They lost between 7 and 9 letters through 2 years. But the second point from a functional perspective, when you look at microperimetry, there was a signal of benefit with treatment towards preserving visual function. And let's talk about that in detail. So remember, microperimetry is a way to test vision across the entire macula. When you check best corrected visual acuity, you're checking foveal function. Microperimetry looks at 68 spots distributed across the 20 degrees of the macula and looks for function in each of those 68 spots. So it's time intensive. It's a test that can be challenging for patients, but really important because it gives you more of a broader functional landscape across the retina. When you look at that in the pre-specified endpoints, which was mean threshold sensitivity and number of scotomatous points, looking at all 68 spots for all the patients that got microperimetry, we saw no differences between the treated arms and the control arm. Of interest, microperimetry was only performed in Oaks. But when we did a peri-lesional analysis, and this was a post-hoc analysis, but it looked at the spots that were just near the edge of the geographic atrophy lesion border, and that represented about 1/3 of the 68 spots. When you do an analysis looking at those microperimetry spots over time, microperimetry is performed every 6 months. When you look at them through 2 years, that's where we saw a signal of preserved visual function with active treatment. And we saw that in the last 6 months, both with less loss of mean threshold sensitivity and also of development of fewer scotomatous points with active treatment. So that was very important data because it's really the first time that we've seen a direct correlation between treatment, which is slowing geographic atrophy lesion enlargement, and preserving visual function. We've always known there's a correlation, a structural function correlation, but never seen a direct benefit before. So that's quite exciting and sort of directs us moving forward where to look for the microperimetry signals, which is right near the border of the geographic atrophy lesions at baseline. So that's a summary of the Oaks and Derby phase 3 clinical trials, which are now completed through 2 years. Again, there's an ongoing separate extension study for all patients, but that's the core 2-year data set. And the next step here is that this drug is being considered by the U.S. FDA as potentially a drug to approve for the treatment of geographic atrophy. I am certainly in no way affiliated with the FDA.
The original PDUFA date for the FDA approval was November 27, 2022. However, the FDA has accepted a voluntary amendment to Apellis' application for pegcetacoplan as an eye injection for geographic atrophy, an advanced stage of age-related macular degeneration. The agency has set a new target decision deadline of February 26, 2023.
If it is approved, that will be a major step forward for the field, because that would potentially be the first therapeutic to be approved for the treatment of geographic atrophy. And that would involve intravitreal injections, either monthly or every other month potentially, for the management of geographic atrophy, which would be a very exciting and new direction for the field to go in.
Please explain what a scotoma is.
So a scotoma is a part of your vision where you don't see. So patients with macular degeneration with geographic atrophy, instead of having sort of a full visual field, like if you have a normal eye and you look at things, there's nothing missing. Whereas if you looked at something and you had dark spots in your vision, or areas that you just didn't see anything, where there's no vision in that zone within your visual field, that's a scotoma. And that's what GA is. It basically, you develop these blind spots in your visions that we call scotomas that get larger over time. So they expand. And they expand until your entire central visual field is missing. You have one large scotoma, or one large blind spot.
Can patients still get involved with this ongoing study?
At this point, there's no enrollment in this study. I must say, broadening the lens here and talking about geographic atrophy treatment in general, there are many ongoing clinical trials. There's currently nothing approved to treat this medication, and there are lots of other ongoing clinical trials which are taking place, I would say, in most urban centers across the U.S., because there are many trials looking at potentially treating this. So if you're interested in getting involved with a potential clinical trial looking at a potential therapeutic, certainly talk to your local retina specialist.